Can I jump in on this point?
I was going to ask you a question. Is we had last year Sir Michael Rollins, who runs NICE,
right.
and that's the big issue: is should cost effectiveness be part of this? Right now, it's specifically not part of the legislation. But should we start to say, bang for the buck? Is this worth it?
Well, we do that now. You go sit with me up at Mayo, and the Mayo people are looking at new technology, and they're going to make a very tough decision on whether they're going to get anything more than a marginal improvement by an extremely expensive kind of purchase. And we do it now in healthcare in terms of expensive, less expensive. We certainly have ratcheted down the amount of invasive surgery that we do versus other kinds of. I mean, we're looking for ways that are quicker, that are safer, that reduce the chance of infection. But we've got to have this kind of research.
Oh.
I mean, at the end of the day, even though you have to make a guess based on what you've got, we've got to have this kind of research.
Dr. Cutler, we have about 1 minute for this topic. Any thoughts on this?
Yeah, I think it's going to go a different way than the NICE way, in the following sense. If you come to those patients, let's say some of whom might get one intervention, like a surgery, and another of whom might get a different intervention, maybe pharmaceuticals, it may be that the difference between how well they do depends on, do they have a spouse at home who can help them recover after a surgery, or remind them to take their pills, or help them to lift bags of groceries if they can't do that on their own. And I think we're not, as the panel there was noting, I think we're not going to be in a one-size-fits-all model. But what we'll do is we'll use a lot of data to figure out how to customize the right treatment to the right person, given all their personal characteristics. And I just sort of draw an analogy between the analysis of medical information to learn how to treat people best and the analysis of stock market information to figure out how to invest best. And there are people who make their living by telling you how to manage your money, and there are a million such people. What we need is at least some of those people to come over to healthcare and say, you know what? We can take these trials and other data that are out there to figure out how to help manage people best, because that's what they want. And we're not going to impose some yes or no. We're just going to help to make it work for people in the way that we can help them in every other setting.
David's really talking about how much the organization of healthcare is significant on producing certain kinds of outcomes. There are other things outside of the medicine itself.
Right. The only thing I would add is there are still some big technical challenges. There is a lot of data, but the data doesn't all come together. Certain outcomes aren't measured, and even as part of this Patient-Centered Outcomes Research Institute, there will be a specific methodology committee set up to try to think about how you harmonize data, how you can collect the right data. There is a lot of data, but I don't think we're as organized
Like
as
the
stock
Sweden
market.
registries.
Right.
Yeah.
But one of the challenges here is that this kind of thinking works when you have a lot of specialists, and you can make those nuanced decisions. So it reinforces a system of specialists. I just got back from Peru. They've dramatically driven down the number of deaths from birth, women's deaths, maternity, mortality. So, and child health is in a better situation. How did they do it? They talked everybody into going to the hospital to have their babies. But whenever there was a complication, they did a C-section. We would be off the wall with the number of C-sections they do. But given their level of skill and the fact that they figured out how to reduce the number of infections in their hospitals, doing a C-section was their way of saving women's lives, protecting the children, where we have a much more nuanced, sophisticated approach to that. But they made some choices based on the skill level of their physicians and their midwives. And so they got everybody to the hospital, and they stopped having babies in their homes. And they've just made a dramatic difference with that. So when we talk about the ability of doctors to have the kind of flexibility based on the data, that works in the United States of America where you have a lot of specialists. That reinforces a system in which we're starting to think maybe we should put more money on the front end versus the other end. So there's got to be a balance here somewhere.
All right.